Hello, everyone, and welcome to this Mental Health Academy live workshop exploring the intersection between trauma and addictions. My name is Pedro Gondim. I'm Mental Health Academy CEO and your host for this session. And joining me from Georgia in the United States is Dr. Amanda Giordano. Amanda, how are you today?
I'm great. How are you doing, Pedro?
Good. Always lovely to connect with you. I think you do about 100 different webinars for Mental Health Academy every year.
I
And
love
then
it.
we have
I'm your
another
biggest fan.
300 calls in between.
I love Mental Health Academy. Happy to do it. Happy to do it.
Yeah, but there's a reason why we are always talking to Amanda because she really knows what she's talking about, and she's got some great insights and practical tools to share with you today. As you're working in the field of addictions, it's a ever complex and changing field, especially with behavioral addictions nowadays. There's so many ways to
Mm-hmm.
get behaviorally addicted, so we're going to cover a lot of that, and obviously with a working through the lens of trauma, which is again another big point of this discussion and very relevant to clinical practice for any mental health professional.
Yeah.
But before we get to the juicy stuff, I want to quickly introduce you to Amanda in case you have not heard about her work. So here is the bio for your presenter for today. Dr. Amanda Giordano is an associate professor at the University of Georgia who specializes in addictions counseling. She's the sole author of the clinical reference book, A Clinical Guide to Treating Behavioral Addictions, and co-author of the textbook, Addiction Counseling, A Practical Approach. Dr. Giordano is also the creator of Mental Health Academy's comprehensive micro-credential courses on clinical work with behavioral addictions and clinical work with substance use disorders. And we share information about both courses throughout the presentation and also in the later handouts that we're going to email to you. As a scholar, Dr. Giordano works to advance the counseling field with rigorous research and has published over 60 peer-reviewed articles and book chapters. In 2018, she received the Addictions Offender, Educator, and Excellence Award from the International Association of Addictions. And in 2024, this year, she was awarded the Gary R. Waltz Trailblazer Award from the American Counseling Association in recognition for her work with behavioral addictions. Dr. Giordano collaborates with domestic and international organizations such as Mental Health Academy to provide training to increase awareness related to addictions counseling. She also maintains a blog titled Understanding Addiction for Psychology Today, which is quite popular, has some really good articles, and is a guest on several podcasts. Amanda, that is a short but extensive bio for you. There's anything else you'd like to add?
Nope, that's everything. I'm excited to dive in.
Wonderful, wonderful. So we're also very excited. But before we get to the session, let me just give you a quick couple of housekeeping items. This is mostly relevant if you're live with us right now. If you're watching this on demand, you can tune out for the next few seconds. So first thing you notice as a webinar attendee is that you cannot talk during the session. However, you can submit questions and comments by using the chat and Q&A functions. So you can interact with your other attendees, and you can also ask questions because at the end of the presentation, we're going to have a Q&A segment to cover many of your questions, clinical questions or otherwise.
Mm-hmm.
Secondly, is after the conclusion of this webinar, usually within 30 minutes, we're going to send you an email with a link to the recording of this presentation, a handout that we prepared specifically with some information and resources, and also the slides that are being used for the presentation today. If you are watching this in the recording mode, so if you're on YouTube right now watching this video as the recording, check out the video description for a link to those resources. And if you can't find or have any trouble, just email us and we'll help you out. Amanda, without any further ado, I am going to launch your slides and I'm going to
Great.
disappear in the background, but I'm looking forward to coming back for our Q&A segment.
Wonderful. Thanks so much, Pedro. And thank you, Mental Health Academy, for having me and for all of the organization for this event. I'm so excited to share this information with all of you. As you know, working in the addictions field, trauma is such a relevant part of what we do. And so I hope that today will be informative as we talk about trauma as a risk factor for addiction. And then we're also going to talk about the need for trauma-informed addictions treatment. So we're going to go ahead and dive right in. So you already heard a little bit about me. I'm just wanted to highlight the last bullet point that I'm really passionate about advocacy. So I love being asked to speak. I love getting this information out to clinicians who are using it in their day-to-day practice. So I hope that you'll find it really useful. All right, so what we're going to cover today, just a little bit about the scope of addiction. And I know many of you might be familiar with this, but a little bit of information about why this is so important. And then we're going to dive into trauma. So we're going to talk about trauma and its various effects. Then we'll move into discussing the relationship between trauma and addiction and why it is a risk factor for addictive behaviors. And then we'll conclude by talking about trauma-informed addictions treatment and what that can look like. And like Pedro said, we will save time at the end for questions and answers, and then you'll get additional resources as well. Okay, so I am in the United States. I work in Georgia in the States. And so a little bit of info just about the current state of substance use in the US that really speaks to the need for these types of trainings because of the prevalence of substance use. So according to the CDC, there were almost 107,000 deaths caused by drug overdoses in the US in 2021. Many of you may have heard of the opioid epidemic, and that's really what we're seeing, that a large number of those overdose deaths involved an opioid, which is the class of drugs that has pain relieving properties. It produces this dreamy relaxation type state. Things like oxycodone, fentanyl, heroin would all fall under this class of drugs. Also in the US, about 16.5% of people aged 12 and older had a substance use disorder in the past year, and over 20 million people consider themselves to be in recovery from active addiction. And so a lot of prevalence in the US, but also when you think about Australia, according to the National Drug Strategy Household Survey, and this was the 2022 and 2023 survey by the Australian Institute of Health and Welfare, among those 14 years and older, 31% engaged in risky alcohol consumption, 11.5% used cannabis recently, 8.3% smoked tobacco daily, 7% vaped currently, 4.5% used cocaine in the past year, and 2.1% used non-medical pharmaceutical stimulants, so non-medical use of those pharmaceutical stimulants in the past year. So again, we could talk globally about the prevalence of substance use, but we know that this is an issue. We know that people are coming to treatment, seeking counseling for addiction, and not only for chemical addiction, but also for addictive behaviors or behavioral addictions. So in the child adolescent sphere, we have pornography exposure. My research team and I did a study, and we found average age of first exposure to be around 11.5 among American adolescents. More than 17% of adolescents across the globe engage in non-suicidal self-injury, which at times can meet criteria for a behavioral addiction. There was a large meta-analysis across studies from 33 different countries looking at gaming addiction among adolescents and found a prevalence rate of 8.8%. When we look at college samples, about almost 15% of college students in China met criteria for social media addiction. Among college students in the US, 11% met criteria for sex addiction. And then in another sample, about 10% met criteria for cyber sex addiction specifically. And then just in the general population of adults, we see that 1.29% engaged in pathological gambling and 2.4% engaged in at-risk gambling. In Germany, almost 8% of adults met criteria for food addiction. And then also among a community sample of adults, almost 5% had shopping addiction. So when we're talking about addiction, that can include substance use disorders as well as these behavioral addictions. So, what I think is going to be really helpful in our discussion about trauma and addiction is understanding that people with addiction are addicted to changing the way that they feel, whether using a drug of abuse or engaging in an addictive behavior. They're experiencing positive reinforcement, which is typically pleasure or euphoria or calm or excitement. It is something that is changing their mood by helping them feel good and find escape from feeling bad. So, a big part of addictions treatment is working with emotion regulation, because we know that people who are using substances and engaging in behavioral addictions are often using these things to manage or regulate their emotional states, to feel good and to avoid feeling bad. I like this quote, using will make predictable what you are going to feel and when you are going to feel it. So using drugs of abuse is going to, in a very predictable and reliable way, change the way a person feels. I think that's important for us to consider because it helps us develop empathy for this population. And it also is going to explain a lot about this relationship between trauma and addiction. So I want to talk briefly about the biopsychosocial model of addiction. And again, this might be familiar to some of you, but unfortunately, the moral model, which says that addiction is the result of a character flaw or a moral weakness, is still prevalent across the globe. So the biopsychosocial model, I think, is a great way to think about addiction because it captures all of the complexities of this disorder. So we know that there are risk factors that can increase an individual's susceptibility or vulnerability to addiction in different areas. So biological risk factors can include genetic predispositions. We know that about 40 to 60%, scholars say, of addiction is linked to genetics. We know that it can run in families. If you've ever done genograms with your clients to look at the family history of addictive behaviors, we can see that often there is this family line component of addiction that is linked to genetics. So genetic predisposition is a potential risk factor. Also, some neurobiological factors that we'll talk about more, but if there are certain susceptibilities or abnormalities in areas of the brain, particularly around the reward center and reward pathway, there's been some recent data that's come out looking at dopamine specifically and dopamine receptors and how some abnormalities in dopamine receptors in reward circuitry could be an indicator of an increased risk or vulnerability to developing addiction. We also know the age when use begins or when engagement in that behavioral addiction begins is a risk factor. So the stage of development of that individual's brain. And typically, the younger a person is exposed to drugs of abuse or behavioral addictions, it increases the risk of developing addiction later in young adulthood and middle and older adulthood. So there are biological factors that contribute to the development of addiction, but there's also psychological factors that can increase a person's vulnerability to addiction. We know that mental health concerns is a risk factor for developing an addictive behavior or a substance use disorder. There are certain personality traits that have been linked and correlated with addiction, like sensation seeking and impulsivity. The history of trauma is what we're going to spend a lot of time talking about tonight or today, this link between early trauma and the later development of addictive behaviors. But we also have to consider the environment and social factors. And so we think about what has been modeled for an individual. What have they seen in terms of substance use and addictive behaviors in their environment, in their immediate setting? What is accessible to these individuals. What can they afford? What can they access? What's available to them? So this biopsychosocial model helps us conceptualize the very complex disorder of addiction by looking at these multiple facets. And there are many things that can increase a person's vulnerability to addiction, falling into biological factors, psychological factors, and social factors. So why I say all of this is we're going to hone in specifically on talking about how trauma is linked to addiction. But I don't want us to think that trauma is the only risk factor that leads to addiction. There are some people who experience trauma and do not experience addiction later in life. And there are others who experience addiction without a history of trauma. So this is just a piece of the puzzle. It's not the whole picture. So I want us to keep that in mind as we go through this workshop. Okay, let's start by talking a little bit about trauma, and then we're going to bring it together into how to understand trauma's relationship with addictive behaviors. So let's just first start by defining trauma, by understanding what this is. So according to some resources like the Psychiatric Association and Van Kolk, who wrote The Body Keeps the Score, which is a great resource about trauma, the description of trauma is that it's exposure to an unbearable, intolerable, distressing event. And it could be things like serious injury, threatened death, or witnessing actual death, sexual violence. All of these are examples of what could be traumatic experiences. I also like the definition proposed by SAMHSA because I think it gets a little bit more nuanced. So SAMHSA says individual trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So I highlighted a couple of words there because SAMHSA really went even further to say when we're thinking about trauma, it could be one event, it could be a series of events, but not everyone is going to experience those events in the same way. So what's really important is to think about how this unique individual experiences that potentially traumatic event. You can have two people go through something very similar and have very different experiences with that event. So we have to consider the uniqueness of the individual, how they are experiencing the potentially traumatic event, and then look at the effects of that event on the individual's life. We see impaired or adverse effects on functioning in a variety of arenas of life, psychologically, physically, socially, emotionally, and spiritually. So what that tells us is that trauma can look very different for different people. It can have different effects, and it can, the same potentially traumatic event can impact people in very different ways. So we want to keep that in mind as we think about trauma. This is just a list of types of trauma. Just want to give some examples, maybe for those who haven't worked directly in a setting that specializes in trauma. But you can just see the diversity here of events and everything from serious accidents and serious injury, any type of abuse, physical, emotional, sexual, any type of neglect. So physical neglect, emotional neglect, medical neglect, bullying or some sort of victimization. Natural disasters are a type of trauma. Violence, and that could be anything from school violence to individual assault, intimate partner violence, terrorism, racial trauma, community violence, the unexpected loss of a loved one. We know that there's trauma in combat, in war. A life-threatening illness can be traumatic, as well as witnessing violence or witnessing abuse or witnessing the death of someone else. So lots of different potentially traumatic experiences. And trauma, unfortunately, is more of the norm rather than the exception. When we look at the World Mental Health Survey, that was conducted in 24 different countries. It revealed that 70% of participants experienced at least one trauma in their lifetime, and 30% experienced 4 or more types of trauma. And so, unfortunately, trauma is prevalent. A lot of people have dealt with trauma and experienced trauma. In these, the World Mental Health surveys, you can see just a little bit more details here that the most commonly reported traumatic experiences were the unexpected death of a loved one, witnessing death and serious injury, being mugged or threatened with a weapon, life-threatening automobile accident, witnessing physical violence in the home, a life-threatening illness. And then we also know from data that experience to one trauma increases the risk of subsequent traumas. And there's a lot of hypotheses and research behind why that might be. But just what I want us to know in today's conversation is that if you have experienced one trauma, you're actually at higher risk of experiencing subsequent traumas. Now, trauma can occur across the lifespan, but I want us to talk specifically about early trauma. So this is trauma that happens in the first 18 years of life, adverse childhood experiences. So you may have heard of ACEs. These are widely studied. There's been some really large scale empirical research projects looking at ACEs, which are traumatic or stressful events during the first 18 years of life. So for the ACEs studies, what they do is they look at categories of traumatic experiences, and they are looking for endorsement of that category. So not necessarily how many times a particular traumatic event occurred, but how many different types or categories of trauma the individual experienced. So in the original ACE questionnaire, there are 10 different categories of potential trauma categories. So individuals who take this questionnaire can have an ACE score of 0 to 10. So it's how many categories they are endorsing. In this original study back in 1998, the roughly 8,500 adults, the scholars found that 52% experienced at least one adverse childhood experience, and 6.2% experienced 4 or more different traumatic categories. And this was from just the general population. This wasn't a clinical treatment-seeking population. So again, speaking to the prevalence of trauma. And what these researchers found is what they called a dose response, that the more categories of adverse childhood experiences that a person endorsed, the higher risk they were for all sorts of detrimental outcomes in adulthood. And those could be physical, medical detrimental outcomes. It could be behavioral detrimental outcomes. So we'll talk a little bit more about that. But as you can imagine, substance use and addiction is a part of those potential detrimental outcomes. I also thought it was important to share among a sample of clinicians who provided data on child clients that they were working with who experienced trauma. The most commonly reported traumatic events from those child clients were neglect, followed by physical maltreatment and abuse, followed by witnessing domestic violence, and then emotional abuse or psychological maltreatment. So these were the most common traumas reported by child clients. Okay, so this is where we really start to dive into the impact of trauma. So what are the effects of trauma on individuals? And remember, like we said before, it can have varying effects on the individual. Not everyone is going to experience trauma the same way. And not everyone is going to have the same either impairments or distress or adverse consequences from trauma. It can vary from person to person. But what we know from research is that trauma can impact a lot of different aspects of how humans function. It can impact coping, so how individuals cope with adversities in life. Trauma can impact executive functions like attention and memory and learning. Trauma can impact mental health and the experience of mental health concerns. Trauma can impact physiological stress response, and that's something we'll dive into a little bit more during this workshop, but it can actually cause changes in our physiological stress response. Trauma can also cause changes in arousal, leading to either hyperarousal or hypoarousal, which we'll talk about a little bit more. Trauma can impact and affect emotion regulation and the ability to regulate one's emotional states. Trauma can affect an individual's beliefs about themselves, the world, others, their cognitions, and trauma can also impact attachment, especially if the perpetrator of the trauma was a primary caregiver, or if primary caregivers maybe responded in one particular way to disclosure of the trauma compared to another way. It can impact attachment and attachment styles. So, and that's not all. This is just what I wanted us to talk about today, that trauma can impact so many different facets of human functioning. So when we think about the effects of trauma, I think it's really helpful to think about it on a continuum. And so we look at how traumatic events affect individuals specifically. So we're looking at that unique individual and how trauma affected them. And it can be on this continuum ranging from really no symptomology, and we call that resilience. So they went through a potentially traumatic experience, but really didn't show a lot of symptoms, and instead they showed this resilience and maybe some positive coping and growth from that. The subclinical symptomology, this would be for individuals who experience a potentially traumatic event and they're not meeting criteria for post-traumatic stress disorder, but they are showing symptoms. They are having a variety of maybe psychological or physical symptoms and reactions because of that traumatic event. And then on the other end of the continuum, we see folks who would meet criteria for post-traumatic stress disorder because of their experience with trauma. And it can really range across this continuum. And so that's something for us to really be able to assess and to see where our clients fall on the continuum when it comes to the effects of trauma on them uniquely. Now, you may be wondering, so what could influence these effects of trauma? Why might some react in one way while others react in a different way, landing at different places on that continuum? Well, there are quite a few influencing factors that can impact how trauma affects an individual. So these factors influence the outcome of trauma. And again, this isn't an exhaustive list. I just wanted to show you some of the different factors that have been noted in the research. That caregiver support and the buffering of an attuned caregiver can really influence the effects and the outcome of trauma on an individual. Social support, and so that can be family support, but also just supportive people in this individual's life. Family connection has been identified as an influencing factor to the effects of trauma, as well as just resilience. And some argue that resilience has a genetic feature to it. Others say that resilience is something that's learned in the environment, but that shows up as an influencing factor, as well as parental stress. So how parents respond to the potentially traumatic experience can have an impact on how trauma affects the individual and the outcome of that trauma. The age when trauma occurs also can influence its outcome. And then genetic predispositions can also influence the effects of trauma and potential outcomes of trauma. And we'll talk about that more specifically when it comes to the relationship between trauma and addiction. Okay, so there were a couple of things from the circle that I showed you a couple slides ago about how trauma can impact multiple facets of an individual's functioning. I want to spend a little bit of time on a few of them that I think really helps us understand this relationship between trauma and addiction. So I want us to understand trauma and the stress response system and how trauma can affect the stress response system. So I think it's important to recognize that the stress response system is really helpful for our survival. It is this kind of built-in mechanism to warn us of danger and help us respond to that danger in a way that promotes survival. So our stress response is healthy, it supports our survival, and when it is operating in a functional way, we identify a danger or a threat, and our HPA axis becomes activated, as well as our sympathetic nervous system is also activated. So what we see is the release of stress hormones, things like adrenaline and cortisol, and we are ready to either run from that threat or that danger or fight it. So this is, you may have heard, fight or flight mode when we are in this state of hyper arousal. So how that affects us in our physical body is we have this burst of energy. So again, we are ready to run, we are ready to fight. Our breathing becomes more rapid in order to get more oxygen in. Our heart is racing, it's beating really fast. We have increased blood pressure. We may tense our muscles, start shaking or sweating, and our attention is like laser focused onto the danger or onto the threat, not other things. So if you were to give us a math test during this state, we're not going to do very well on the math test because we are so focused on that threat or that danger. We have all of this activation of our HPA axis and the SNS, our sympathetic nervous system. So we're ready to go, and then we respond. We either fight off the danger or the threat, we run from it, but somehow we respond, and the threat or the danger is over. When this happens, our stress response, which has been activated, is going to return to baseline. So the stress hormones start to dissipate, our breathing returns to normal, our heartbeat returns to normal, we start focusing on other things again, and we really return to baseline. That is how our stress response system is supposed to operate. And again, it's a really helpful and healthy thing. Now, unfortunately, trauma can disrupt how our stress response system is supposed to operate. So, especially in times of toxic stress. So toxic stress can occur with chronic or prolonged trauma. And this is stress resulting from these traumatic experiences that is strong, it's prolonged, it's unpredictable. And it's also occurring in the absence of that buffering that comes from an attuned caregiver. So this is where toxic stress can occur, and it impacts our stress response system differently. So in the state of toxic stress from these chronic or this unpredictable trauma, the threat or the danger may be persistent. Perhaps it lives in the home or in the neighborhood or in the community. So the threat, the danger is chronic, it's persistent. And so for these individuals who are experiencing this chronic trauma, their stress response system is always turned on. It's chronically activated. So these individuals don't return to baseline, but they live in this state of hyperarousal. They live in that fight or flight mode. So for these individuals experiencing toxic stress, the HPA axis is continually stimulated. They have these elevated levels of cortisol and adrenaline just coursing through them. And so what that looks like over time is increased blood pressure and increased heart rate, increased speed of breathing, some irritability, sleep problems, increased blood sugar and inflammation, a compromised immune system, as well as attention and memory issues. And I like how Mo put it, that this just causes wear and tear on the body and can lead to chronic illness and long-term health issues because our stress response system was not designed to be chronically activated. It was supposed to be activated when there was a threat, and then we return to baseline when that threat is resolved. But in instances with chronic trauma and persistent trauma, these children and these individuals may have a stress response system that is always active. It's chronically active. And so that toxic stress in childhood can change the functioning of the stress response system, leading to a dysregulated stress response system, where again, it is chronically activated and they're living in this state of hyperarousal. It's as if they're living in fight or flight mode. So this dysregulated stress response can persist into adulthood, even after maybe the chronic and persistent trauma has ended. It can persist, that this becomes the way the individual knows how to be in the world. And so, as you can imagine, individuals with dysregulated stress response, they have difficulties regulating their emotions. It's difficult to self-soothe. It's difficult to manage their emotional states to cope with some of that hyperactive fight or flight mode feelings and experiences. And we know that individuals with difficulties regulating their emotions are at higher risk of using drugs of abuse or engaging in addictive behaviors. So difficulties with emotion regulation is a strong predictive factor of addictive behaviors. And so we know that this toxic stress leading to a dysregulated stress response, which can lead to difficulties with emotion regulation, can increase an individual's vulnerability to addictive behaviors. I want to dive into a little bit more. It's connected to the stress response system, but more specifically, how trauma impacts arousal. And so, like we just talked about, with a dysregulated stress response system, we have individuals that can be living in fight or flight mode. So trauma can lead to hyperarousal, which is this state of being hypervigilant, really high emotional reactivity, increased alertness. It's as if the individual is trapped in that fight or flight response, even after the trauma has ended. So they're living in that hyperarousal. But for other individuals, when they experience trauma, it leads to hypoarousal. So hypoarousal is what you would imagine. It is kind of the opposite experience. So it's a numbing of the self. It's reduced emotional responses. It's detachment from one's emotions, immobilization. It's as if this individual is trapped in a freeze response. So we've heard of fight, flight, or freeze. And so that freeze response is what we see with hypoarousal, just detachment, a numbing of one's emotional experiences. So what we see in the literature is that individuals who've experienced trauma have higher reactivity to everyday stressors. Vanderkolk said that for traumatized people, stress hormones spike quickly and disproportionately in response to mildly stressful stimuli. So responding very strongly to a mild stressor. And that is something that we see with traumatized individuals. Also, Ogden said traumatized people are usually so sensitized by past traumatic events that they have very low thresholds for relatively minor stressors, responding with the extreme arousal adaptive in the past, either becoming hyper aroused or becoming hypo aroused. And so we see this continuing after the trauma has ended, these effects of trauma on the arousal system, on how we respond to stress. And that has implications for addiction. So I want us to take all of that information that we just described about trauma and now use it to understand this relationship, and very robust relationship, between trauma as a risk factor for later addictive behaviors. So first, I think it's really important to recognize that there is a bidirectional relationship between trauma and addiction. So for some individuals, trauma can come first. It can precede the addictive behaviors. And addictive behaviors might be this individual's best attempt to cope or manage trauma symptoms. Also, addictive behaviors that are out of control and compulsive, and people are using substances and getting into these states of intoxication, it can put people in risky situations And also, continued substance use can actually compromise executive functioning and decision making. So maybe making decisions that aren't best for this individual and their safety. So they may be at higher risk of experiencing trauma after addiction begins. So we see this kind of cyclical, bidirectional relationship between trauma and addiction. So I just wanted to note how common trauma is among those with addiction. For those of you who work in the addictions field, it's very likely that you have heard your clients talk about early trauma or adverse childhood experiences. Trauma is a strong predictor, a strong risk factor of later addictive behaviors. So there was a meta-analysis of 10 different studies across 6 countries, and they found that trauma among those with substance use disorders was higher than the prevalence of trauma in the general population. Specifically, among those with substance use disorders, the scholars found that 38% had experienced emotional abuse, 36% had experienced physical abuse, 32% experienced physical neglect, and you can go on and on. So we see from these meta-analyses that the prevalence of trauma is higher among those with substance use disorders. Also, there was a review of 80 different studies, and they found a really robust association between ACEs, so adverse childhood experiences that occurred before 18 years of age, and substance use in early adulthood, so substance use that began before age 25. And again, that was a recent review of 80 different studies. Also, we saw in the literature a meta-analysis of 102 studies in multiple countries that found a significant pooled effect size between ACEs and smoking, heavy alcohol use, ACEs and problematic alcohol use, ACEs and cannabis use, and illicit drug use. So that pooled effect size is just telling us that this is not due to chance, that looking at these 102 studies that have looked at adverse childhood experiences and various forms of addictive behaviors, we found a significant pooled effect size. So there is this relationship that is not due to chance. And then finally, a meta-analysis of 37 studies conducted in 12 countries found a positive medium pooled effect size between ACEs and internet addiction. So I want us to be thinking about addictive behaviors as including chemical use, but also behavioral addiction. So chemical addiction and behavioral addiction have been linked to early trauma. So I found this table very compelling. There have been so many studies that have looked at adverse childhood experiences and detrimental outcomes in adulthood. And some of those detrimental outcomes include addictive behaviors and substance use behaviors. So I want you to take a look at this with me, that this first row are individuals who reported an ACE score of 0, meaning that these individuals did not endorse any trauma category in the first 18 years of life. So like we said at the beginning, trauma is just a piece of this puzzle. It's not the whole picture. So 3.1% of individuals self-reported alcohol use disorder, even though they had no ACEs. 0.8% of those who ever used illicit drugs and were addicted to illicit drugs did not have any childhood trauma that they reported. So you can see that first row are individuals who are saying no childhood trauma, no ACEs, and you can see the prevalence rates of substance use, severe obesity, which can speak to food addiction. In some ways, it could be relevant to food addiction, 50 or more sexual partners, which could be relevant to sex addiction, early smoking initiation, and heavy digital media use among youth. So those without trauma can also have these addictions, these addictive behaviors. But I just want you to look at how these numbers jump in that second row. So the second row are for those who had an ACE score of 4 or more. And you can just see how these numbers jump. So self-reported alcohol use disorder went from 3.1% up to 16%. Ever addicted to illicit drugs went from 0.8% to 13.1%. Even down at the end of this table, looking at heavy digital media use among youth went from 19% to 41%. So this is something we have known for decades. You can look at some of the dates of these studies, and some of them are fairly dated, but we have seen this dose response between adverse childhood experiences and later addictive behaviors. Just a little bit more that speaks more to the behavioral addictions. Among 149 men in the US who screened positive for sex addiction, they had more experiences of early trauma than those who did not screen positive for sex addiction. Childhood trauma also significantly predicted internet gaming disorder among both Chinese university students and South Korean adolescents. And childhood trauma significantly predicted social media addiction among Iranian adults. So we're seeing with behavioral addictions, with chemical addictions, this link between early trauma, childhood trauma or adverse childhood experiences, and later addictive behaviors. So what I think is so fascinating is that we have known this since at least the 1990s, if not before. And Felitti, one of the scholars who did that original ACE study, just made meaning of that relationship between adverse childhood experiences and addictive behaviors in this way. Felitti said the linking mechanisms appear to center on behaviors such as smoking, alcohol or drug abuse, overeating, or sexual behaviors that may be consciously or unconsciously used because they have immediate pharmacological or psychological benefits as coping devices. So we've known this for decades, that individuals who have experienced trauma in early childhood may be turning to those experiences or those drugs of abuse that change the way that they feel. Remember, we talked about how people with addiction are addicted to changing how they feel, that these drugs of abuse are positively reinforcing. They are also negatively reinforcing. They take away something undesirable like depression, trauma symptoms, anxiety, boredom, loneliness. So when we think about drugs of abuse and addictive behaviors and how they work in the brain, how they stimulate that reward pathway, causing the release of dopamine and other neurotransmitters that are implicated in the experience of reward, we understand that these drugs of abuse and addictive behaviors can change the way a person feels. And a person who has experienced trauma may be more at risk to using these behaviors and using these substances as a way to manage or regulate their emotional experiences, or like Felitti says, as coping devices. So I just want you to take a look at, these are just select symptoms of PTSD. And so this is from the DSM-5. These are symptoms of PTSD. Just a couple here that I'll highlight: distressing, recurrent memories or dreams of the trauma, flashbacks as if the traumatic event is reoccurring, persistent and exaggerated negative beliefs, persistent avoidance of trauma cues, diminished interest in activities, feelings of detachment, the inability to experience positive emotions, angry outbursts, hypervigilance, sleep disturbances. If you are living with those symptoms and you come across a drug of abuse or a potentially addictive behavior that predictably and reliably changes the way that you feel, we can start to understand some of this relationship, that individuals with trauma symptoms are at higher risk of coping through addictive behaviors than those that don't have trauma symptoms. For their, again, the positive reinforcement of feeling euphoric and pleasure, but also that negative reinforcement, the escape from suffering or relief from suffering. And so that really helps us start to understand this relationship. Van der Kolk said that traumatized individuals, they have a higher risk of self-medicating or dulling the inner world with drugs of abuse or other means. Specifically, Van der Kolk said, "We'll do anything to make these awful visceral sensations from trauma go away, whether it's clinging desperately to another human being, rendering ourselves insensible with drugs or alcohol, or taking a knife to the skin to replace overwhelming emotions with definable sensations. So this idea that it becomes a potential coping device to use drugs of abuse or engage in these potentially addictive behaviors like sex addiction, non-suicidal self-injury. And so what we see is that trauma can lead to changes in arousal, like we've talked about before. Now, hyperarousal feelings are just overwhelming. So when people are hyper aroused, they're overwhelmed with their emotions. They're in that fight or flight mode. They're hyper vigilant. Some drugs of abuse and addictive behaviors have a calming intoxication effect. So the benzodiazepines, Xanax, the alcohol, opioids like Percocet or Oxy, cannabis products, they can actually have a calming intoxication effect, which could seem like a way to regulate hyperarousal. Also, gaming and gambling have been discussed as producing this trance-like state that people kind of get lost in this trance while they're gaming or while they're in front of the electronic gambling machine. That can produce these feelings of calm. And on the other hand, for people who are hypo-aroused, where feelings are not overwhelming, they're really absent. There's this numbing, there's a detachment from one's emotional experiences. Some drugs of abuse and addictive behaviors have an excitatory intoxication effect. So the stimulants like nicotine, cocaine, and meth, some of the ADHD medications, amphetamines, even some bath salts can have this excitatory intoxication effect, which again might be hard to walk away from someone who has experienced hypoarousal and this numbness. The same with sexual activity, exercise, non-suicidal self-injury. All of these may be used as a means just to feel something when someone feels numb. So again, we can start to see some of the connections between trauma and the effects of trauma, and then the potential use of addictive behaviors as a means of either dulling the inner world, coping with hyperarousal, and managing one's emotions and emotional states. So, why is trauma a risk factor for addiction? A couple of different reasons have been proposed. The one that we've been discussing during this workshop is that trauma causes an array of symptomology, and drugs of abuse and addictive behaviors can be used for emotion regulation and coping with those trauma symptoms. So that's what we've been largely discussing. But also, substance use and addictive behaviors can be used as a means of reenacting trauma. So telling the story of trauma or reenacting aspects of trauma through addictive behaviors. Or these addictive behaviors provide the illusion of control for individuals who feel out of control because of past trauma. Also, another potential reason why this relationship exists is early trauma can cause disruptions in cognitive development and impairment in executive functions. Remember, we also talked about how one of the potential effects of trauma could be impacting executive functions. So for individuals who have disruptions in their cognitive development or have impairment in executive functions, they may engage in more impulsive decision making. They may have deficits in just self-regulation, which is one of those executive functions, which might lead to more substance use or a higher risk of substance use or addictive behaviors. And then finally, another potential reason explaining this relationship between trauma and addiction is that trauma may have caused attachment failures and led to insecure attachment styles when an individual was young, and then they turn to substances or these addictive behaviors in an attempt to find secure attachment. So they are turning to addictive behaviors, drugs of abuse as a replacement, a way to try and find secure attachment. So those are some of the bigger hypotheses explaining this robust relationship between trauma and addiction. I wanted to dig down a little bit more into trauma attachment and addiction. And there are a lot of resources out there about how addiction can be perceived through an attachment lens. And so we know that childhood trauma can cause attachment failures. It can lead to insecure or disorganized attachment styles. And then some of those individuals may find that addiction is, albeit an ineffective, but it's a substitute for that missing attachment. And so I like this quote: when attachments are troubled, individuals often substitute chemical connections for human ones. So some individuals may develop inanimate attachments to addictive substances or behaviors due to the attachment wounds from childhood, these attachment ruptures or failures, and insecure or disorganized attachment styles. So what does that mean for treatment? When we're working in addictions treatment, we understand that this relationship between the client and their addictive behavior may have deeper levels of meaning. We try to understand the client's attachment to the drug of abuse or addictive behavior. And when, again, I like this quote: when a client decides to stop the addictive behavior, she is in effect making the painful choice to say goodbye to a loved one, a main carer, a partner depended upon for rescue from all difficult situations. So there is that attachment piece when we look at addiction, and then starting recovery and entering into sobriety and abstinence can actually come with some emotional pain that is linked to this attachment ending. So what we also know from this attachment lens is that group counseling and peer support groups can be really important elements of addictions treatment, especially with individuals with trauma. So if individuals with trauma are showing up for addictions treatment, getting them in groups, getting them in peer support groups could be really helpful to learn to develop healthy attachments and new attachment patterns with group members, with counselors, with peer support group members. Also, that means a lot for us as clinicians, that attunement and containment for our client, collaboration and secure attachment from the counselor are important with traumatized clients who have a substance use disorder or a behavioral addiction, that all of those things can actually be corrective experiences for these clients. And then I just think we also have to consider the environment. I think when we are working in the field of addictions, and especially from the biopsychosocial model of addictions, we care about biological factors, we care about psychological factors, but we also care about social and environmental factors as well. So I just wanted to point out that in the original ACE study, the most commonly reported category of ACEs was living in a household with substance use. So 25.5% of the participants in that original study endorsed this particular category of early trauma, living in a household with active addiction, with substance use. So that can mean a lot. So think about the child that's living in the home with active addiction, that these addictive behaviors can actually be influenced by social learning, by modeling, by what they see in the home, by what they start to perceive as a viable option for coping with life stressors or celebrating having a good time. That starts to be modeled. So living in a home in which trauma from parental active addiction is experienced can have an impact on the development of addictive behaviors among those children that were living in the home. So substance use and behavioral addictions may be modeled, they may be accessible, they may be available. So again, it's really important for us to consider the environment and the setting and the social factors that can contribute to an increased risk for developing addictive behaviors. Also, like I've said several times, that trauma is just one piece of the puzzle. It's not the whole picture. So I found this study to be really interesting. The scholars were looking at trauma and heritable factors that among the participants in the study and found that they interact with each other. So in that original ACE study, the ACE scores associated with alcohol misuse, that relationship was present between ACEs and alcohol misuse, regardless of parental history of alcohol use disorder. So even with those that did not have a family history or parental history of alcohol use disorder, if they experience adverse childhood experiences, we still saw an association with alcohol misuse among those individuals. But among those with the same ACE score, so the same amount of trauma categories endorsed, the likelihood of alcohol misuse was always higher among those with a family history of alcohol use disorder. So that's the point I wanted to make when we talk about how genetic predispositions can influence the effect of trauma on individuals. So if one person experiences trauma and they have a genetic predisposition for addiction, they may be at higher risk for using substances or engaging in addictive behaviors than someone who experiences trauma but doesn't have a genetic predisposition for addiction. And, I get asked sometimes, why do some people experience trauma and they end up with a substance use disorder, but others experience trauma and they go in a totally different direction? It's very unique to the individual, and it's influenced by lots of factors. But we know, and from studies like this, we see the influence of genetics, that if you have family history of alcohol use disorder, your likelihood of experiencing trauma and then engaging in alcohol misuse is higher than those that don't have that family history. So we have to consider how our genetics and our environment and nature and nurture influence each other. And so I thought that was a really fascinating study. So this brings up a couple of things, and we're going to spend the next really 30 minutes just kind of diving into what does this mean for treatment? What does this mean for assessment? But I want to highlight the importance of early intervention. And so when I talk to counselors in training who want to work with children, either in schools or in communities, I tell them that when you identify children with trauma histories, and you either provide the services that they need or connect them to the support services they need, the mental health professionals that they need, that actually is preventative work against future addictive behaviors. So trauma-informed care and child counseling can be prevention and preventative measures against adolescent and adult addictive behaviors in light of this very robust relationship we see between early trauma and later addiction. If we can intervene early and we can provide the services that are helpful for that child who has experienced trauma, that could change the trajectory in a way so that they are not at higher risk for developing addiction later. And so I think that's just, I always tell my students that are working with young people or aspiring to work with young people that I bet you didn't think about that's actually preventative work against addiction. Okay, so let's spend the rest of our time before the Q&A segment just talking about trauma-informed addictions treatment and what this can look like. When we're coming from a trauma-informed lens, sometimes I get asked, so how is trauma-informed addictions treatment any different than just standard addictions treatment? And it's going to have a lot of similarities, but I think one of the main distinctions is that from a trauma-informed lens, we are considering and we're helping our clients consider the interdependence of trauma and addiction. So as counselors, as clinicians, we are recognizing that trauma and addiction can interact and they can influence one another, but we're also helping our client explore that as well. So it's beneficial to explore with our clients this relationship between trauma and addiction. So using substances or engaging in addictive behaviors might be our client's best way to cope with trauma symptoms because they're seeking that negative reinforcement, that escape from suffering, that relief from suffering. But also, trauma flashbacks or trauma memories might occur while the individual is intoxicated or while they are using drugs of abuse. And so we have to explore with our clients this interaction and how trauma and addiction influences one another as part of the treatment process. Now, I just also wanted to mention there is a need for trauma-informed care across the board. Trauma doesn't look a particular way. Like you saw in the statistics, more people experience at least one trauma in their lifetime than not. And so trauma can impact anyone. But we also know from data that trauma may be more prevalent among clients who present to addictions treatment who are refugees, or who don't have stable housing, who have served in the military or are currently serving in the military, who are first responders, who are members of marginalized racial and ethnic groups who've experienced either generational trauma or racial trauma. So all of that to say, trauma plays a role in mental and substance use disorders and should be systematically addressed in prevention, treatment, and recovery settings. So again, trauma can impact anyone, but if you're also working with a population where prevalence of trauma is known to be higher, then we definitely need to assess our prevention, our treatment, our recovery protocol. Do we assess for trauma? Is this setting trauma informed? And so that's just something I wanted to highlight, that this really should be done everywhere, but we also have special consideration for those populations that may have higher prevalence rates of trauma. So regardless of our addictions setting or our recovery setting, we really need to consider trauma-informed care. And when you're just diving into what is trauma-informed care, I really like this. It's not what's wrong with you, but what happened to you. So it's a very different perspective. We are considering the potential role of trauma in our clients' presentation and current behaviors. And so could trauma have played a role? And again, like we've said, not all individuals who present for addictions treatment are going to endorse ACEs or endorse a history of trauma. They may have experienced some traumas after substance use was initiated because of that bidirectional relationship. They may have found some of their experiences with drugs of abuse or addictive behaviors to be traumatic in and of themselves. But I don't think we can't assume that everyone we see is going to have this trauma history or going to endorse adverse childhood experiences, because that's not what we see in the research. Instead, this is a part of this bigger biopsychosocial model of addiction, and something that we should assess for. So one of the groups that I mentioned previously were veterans and service persons. And I just wanted to highlight, because it's something that's becoming more and more prevalent in the research and in the literature, is this idea of moral injury. So first, 6.2% of veterans had a substance use disorder in the previous year. So a substantial number of veterans had a substance use disorder. Another study reported that among 195 veterans in treatment for substance use disorders, you can see the prevalence of different types of trauma: physical abuse, emotional abuse, sexual abuse. And then 36.4 reported that their most traumatic experience was in the military. Among a national sample in the US of veterans with combat and war zone exposure, lifetime trauma was a significant predictor of substance use disorders. And potentially morally injurious events were associated with an increased odds of substance use disorders. So in case you haven't heard that term before, moral injury is defined as either engaging in or failing to prevent or witnessing events that contradict deeply held values or morals. So that is referred to as moral injury. And the research around this is just burgeoning. We're seeing it a little bit more and more each year, but there is some evidence to say that potentially morally injurious events were associated with increased odds of substance use disorders among a veteran sample. So just something else to keep in mind as it's becoming more prevalent in the literature. Okay, so I wanted to talk about what is a trauma-informed approach. If we were going to assess our work and our work as clinicians with populations with substance use disorders or behavioral addictions, what would trauma-informed work look like? Well, the trauma-informed approach is defined by these 4 R's. The first is realization. So understanding how trauma can impact individuals and communities. So for us in addictions treatment, that means knowing and getting training on the ways in which trauma is related to addiction, like I hope you've experienced in this workshop, understanding and realizing the interconnectedness of trauma and addiction. So that's the first R. The second R is recognizing. So recognizing the signs of trauma. And you can do that in a lot of ways. One might be utilizing appropriate screening tools and assessment instruments to assess for childhood trauma, to assess for trauma across the lifespan. And we want to assess trauma with all clients with addiction. Just in light of the prevalence of trauma, in light of the heightened prevalence of trauma among those who have substance use disorders and engage in behavioral addictions, we really want to assess with all of our clients. And then we want to respond. So we want to apply principles of trauma-informed approaches and evidence-based trauma practices to our work. And that's what we're going to talk about for the remainder of this workshop. What are some of those evidence-based trauma practices when it comes to addictions work? We want to utilize these integrated approaches that address trauma and addiction simultaneously. And there are many that are out there. We're just going to cover some tonight, but you'll get additional resources as well. And then finally, the last R is resist re-traumatization. And you may be thinking, well, how can I as a counselor re-traumatize someone? But we want to be careful that we're thinking critically about our practices and all of our policies to avoid policies and practices that could potentially re-traumatize individuals. So some examples that are given are using restraints with clients, using seclusion or seclusion rooms with clients. Even it's been proposed that a distant and non-relational counseling approach may be re-traumatizing to an extent for a client who has experienced trauma. So we really just want to think through all of our work and all of our practices to ensure that we are considering trauma in what we do and ensure we're not re-traumatizing clients in any way. So you may be thinking, that sounds great, Amanda. I would love to screen for trauma. What are some screening and assessment tools? There are many. So I just put some of them on this slide if you want to consider integrating them into your practice. And remember, when we think about our ethical codes, we only want to use assessment instruments where we have been trained and we have the competence and expertise in that area. But there are lots of different screeners and assessment tools looking for PTSD, the life stressors checklist, revise, trauma history questionnaire. I won't read through all of these, but the life events checklist is based on DSM-5 criteria. There's moral injury scales, trauma history screens. And so again, you can look for what is the screening tool or the assessment tool that is most appropriate for your setting, getting training on the use of that measure or the use of that screener, and then starting to assess for trauma regularly and systematically in your work. Now, there are 6 different principles of the trauma-informed approach. There's a lot written on this from SAMHSA, and those resources are readily available. So I'm not going to go into a deep dive into all 6 of these. I just want you to be aware that these 6 principles of a trauma-informed approach consist of safety. And so in your setting, in your organization, is there a sense of physical and psychological safety in the physical space and the interpersonal interactions? Is there a sense of trustworthiness and transparency? So transparency of the operations and how decisions are made. And the goal is really to build trust with those in the organization or the clients who use your services and maintain that trust. I love this one as an addictions counselor. The third principle is peer support. So utilizing mutual self-help and peer support as a way to establish safety, build trust, foster hope, and aid in recovery. I think the addictions field has been doing that for a really long time, and now it's being recognized as an important principle of a trauma-informed approach. Collaboration and mutuality. So you want to try and level power differences to the extent that it's possible, share decision making. And then the belief is that healing occurs in relationships and in partnerships that are collaborative. So really respecting the autonomy of our clients and drawing them into this collaborative shared decision making process. The fifth principle is empowerment, voice, and choice. So we recognize the strengths of our clients, of those who utilize our services in our organization. And after we recognize their strengths, we build upon them. We're trying to foster resiliency in those who use our services. We want them to self-advocate. And find healing. And then finally, the last principle of this trauma-informed approach is cultural, historical, and gender issues. So we are trained to be multicultural, competent, and counselors with cultural humility. We want to have cultural sensitivity, and that means addressing our own biases that can, again, make the relationships or the settings seem unsafe. So we want to address biases, utilize culturally responsive services. So it's not one size fits all, but we're really relying on our multicultural and social justice counseling competencies to inform our work, recognizing the impact of historical and generational trauma and how that might manifest in different addictive behaviors. So these are the principles of a trauma-informed approach. And again, if you're interested, SAMHSA has a great resource that dives even deeper into those. But for the time remaining, I really want to highlight just a couple of integrated approaches that address trauma and addiction simultaneously. And you may have heard of these, but hopefully this will give you a little bit more insight into them, and you might want to check them out on your own to learn more. So seeking safety, I think, is in the circles where I work in the addictions field and addictions research. This is the one that I hear the most about. Seeking safety is a manualized, structured treatment for clients with post-traumatic stress disorder and substance use disorders. And it's really based a lot on CBT, cognitive behavioral therapy. Now, again, what makes trauma-informed addictions treatment is that understanding the interconnectedness of trauma and addiction and exploring that with your clients, understanding it yourself in your own conceptualization of your client. So that's what happens in seeking safety. There's this understanding of the interaction between substance use and trauma symptoms, how they trigger each other, how they're interrelated. That sometimes abstinence from drugs of abuse can lead to worse trauma symptoms. And so how do we develop a plan to help prepare our client for that, to set them up for success, to ensure the support system and the coping mechanisms are in place in order that if trauma symptoms worsen, they have a plan, they know what to do, they have the support that they need. Now, seeking safety can be delivered in group or individual format for adolescents or adults of any gender. And basically, this manualized treatment has 25 different topics, and you don't have to do all 25. You don't have to go in order, but these topics are relevant to both addiction and trauma. And so, some of the central ideas is establishing safety and what that means for the client in terms of their trauma history and in terms of their addictive behaviors. Treating addiction and trauma simultaneously. So that's the integrated approach. It's the same counselor addressing both. Restoring the client's lost ideals. So they may not be living according to their values, either because of trauma or because of their substance use. And so helping them reclaim those lost ideals. Emphasizing the process of the counselor. So the counselor's presence and being is important. It's not just this kind of cold manualized treatment, but compassion, the therapeutic alliance, modeling, all of that is integral in the seeking safety approach. And then you're going to see content in 4 areas: cognitive, behavioral, interpersonal, and case management. So all of those are addressed in the 25 different topics. Importantly, seeking safety does not include exploring the trauma narrative. Like, there are some trauma approaches where a trauma narrative is either written or shared orally. That's not a part of seeking safety, with the idea in mind that sharing the trauma narrative or getting deep into the specifics of the trauma could lead to more engagement in addictive behaviors. So I just wanted you to see an example of some of the seeking safety topics. So the session format is really just a check-in. So how are clients doing? You read and discuss a quote that is inspirational in nature. You teach and demonstrate whatever the topic is for that session, and then help the clients apply it to their lives. And then you have a checkout, which is asking what stood out from the session. So these treatment topics are going to be relevant to addressing trauma as well as addressing substance use disorders. So things like asking for help, compassion, honesty, integrating the split self, self-nurturing, healing from anger, coping with triggers. Those are just some examples of treatment topics that are part of seeking safety. And this is just an example of what one session could look like. The session is detaching from emotional pain, and the topic is really teaching and then having clients apply the skill of grounding. And grounding can help a client detach from drug cravings, but also it can help them detach from intense trauma-related negative feelings or memories. And so it's, again, relevant to both. And so I won't go through all of this, but this is what's in the Seeking Safety manual, is what this session could look like. Okay, so the next one I want to introduce you to is Atrium, which is Addictions and Trauma Recovery Integrated Model. So Atrium is really the process of helping clients understand how their current addictive behaviors connects to past trauma. So what we've been talking about, understanding that that interconnectedness. So the idea is that trauma-related distress activates addictive compulsions, that as trauma is left unaddressed, we're going to continue to see these addictive behaviors. And that addictive behaviors are, in some sense, a logical response to trauma. It's a way to predictably and reliably change the way that they feel. So part of Atrium is helping the client understand what's called the triadic self, which are these internalized roles of that are prevalent in the trauma narrative. So victim, abuser, and the non-protecting bystander. These are typical actors in childhood trauma scenarios and could be internalized by the client. And then that is what is reenacted in what's called the trauma reenactment, which is this triadic self, those internalized roles, trying to tell the story of childhood trauma by engaging in addictive behaviors. So using addictive behaviors as a way to tell the trauma narrative or reenact the dynamics of the childhood trauma experience. So the idea behind Atrium is that clients get caught in this trauma reenactment, that addictive behaviors are used to tell the story of trauma, to display and show others the dynamics of that traumatic experience, could reinforce the belief that the client can't protect themselves, recreate destruction caused by the perpetrator in early childhood, again, give the illusion of control. So Miller and Goudry said, "We understand these addictions as having been the best ways the trauma survivor knows to express the painful dynamics of her trauma experience." So the goal is to help clients connect their present addictive behaviors to their past trauma, and then develop what's called a protective presence, which is this internalized sense of protection or a comforting resource. So I won't go through all of this. You can get this from the Atrium manual, but it is also an integrated manualized model for trauma survivors with addiction. It is, the creators of Atrium say it's appropriate for adolescents, adults of all genders. It lasts 12 weeks. With 90-minute weekly sessions. It was designed for groups, but it could be used in individual formats as well. And it really emphasizes that mind-body-spirit connection. With the ultimate goal of helping survivors find less painful ways to express their life stories so that they may leave the trauma reenactment behind. And just moving along to internal family systems. So I wanted to highlight this one as well. And so internal family systems, if you're familiar with IFS, this is systems theory applied to the mind. And so I actually first learned about internal family systems when I was interviewing a clinician for my book on the chapter of pornography addiction. And he talked about how he uses IFS as a way to address pornography addiction in his clients and has experienced a lot of success. And so I was like, this is very fascinating to me. Let me get this book. Let me start listening to podcasts, trying to understand internal family systems. And it is very fascinating. It's been applied to work with trauma and addiction. So it's a systems theory applied to an individual, looking at their mind as containing different parts that are working as a system. And so again, there's great resources about it, but I just want to kind of highlight a few things that makes it unique. From an internal family systems perspective, there's the self. So that's a part of the mind. That's kind of the inner leader or the core sense of consciousness. There are parts called exiles. And so these are parts that carry emotional pain. So for traumatized clients, that would be the part of them that carries the pain of trauma, has been injured by trauma. And then there are other parts called protectors. So these protectors can be managers or firefighters. So they have some unique names here, but the protectors are trying to keep the exiles from becoming activated. And so they will do whatever they can to suppress the exiles' emotions, keep the exiles out of mind. Managers do that by trying to control everything, where firefighters do that by trying to distract from the exile that's being activated. So the goal of internal family systems is to help clients separate from their parts and restore trust in the leadership of the self. And so separate from their parts, meaning that the client is not trauma. The client is not addiction. The client has a part of them that has experienced trauma. The client has a part of them that uses substances, but that's not the whole of who the client is. So you're trying to create harmony between these parts. When you look at internal family systems for trauma and addiction, this is actually something that van der Kolk referred to in his book, The Body Keeps the Score, but there have been others who have written about using IFS for different addictive behaviors or experiences of trauma. But the client is conceptualized in the following way. So you recognize that the client is comprised of a system of inner parts, including the exile, which is the part that was injured by past trauma. The exile is frozen in the past, carrying all of the emotional pain and can be activated, causing these overwhelming emotions. So for clients with trauma and addiction specifically, they say that the protector that's most activated is the firefighter. And so the firefighter is employing the addictive behaviors as a way to distract from the exile's emotional pain, a way to distract or numb or soothe from the exile's emotional pain. So the firefighter is dominating this internal system as a means of protection. And so van der Kolk said, anyone who deals with trauma survivors will encounter those firefighters. I've met firefighters who shop, drink, play computer games addictively, have impulsive affairs, or exercise compulsively. So really listing out chemical and behavioral addictions being employed by the firefighter as a means of distracting from the pain and the overwhelming emotions of the exile. So the goal from an IFS perspective then would be to help the client separate from their parts so they're not their addiction and they're not their trauma. Instead, a part of them is using addictive behaviors and a part of them has been traumatized. You're not trying to eliminate any of the parts. Like the firefighter that's employing addictive behaviors. We're not trying to eliminate the firefighter, instead trying to change the firefighter's extreme roles and extreme strategies for dealing with the exile. Trying to understand that the firefighter is doing its best to extinguish the emotional pain of the exile. So in IFS, there's this process of maybe asking the firefighter to step aside so that the exile, the traumatized part, can be addressed by the self, that inner consciousness, that inner leader. The self and exile can form this trusting relationship. The self can ask the exile what it needs in terms of being heard, in terms of being validated. Unburdened is one of the words used in IFS. And then when this happens, the firefighter, the use of those addictive behaviors, can take on a new role. So by addressing the trauma and unburdening the exile, that is then addressing the addiction, giving the firefighter, that protector, a new role. So in stating that balance and harmony between the parts while relying on the self. There are others. I mentioned there's quite a few integrated models that would address trauma and addiction simultaneously. There was an interesting study. It was an adapted version of the cognitive processing therapy model. And so this is a cognitive behavioral approach that's trauma focused, but it was culturally adaptive for use with Native women to address both PTSD and substance use, as well as high-risk sexual behaviors. And so the results were promising. There was a controlled trial that showed decreased PTSD symptoms and alcohol use and sexual risk behaviors at the end of treatment. And so I just wanted to note that one. And it's also an example of a culturally adapted approach. And then also concurrent treatment of PTSD and substance use disorders using prolonged exposure. So that's called COPE. And it addresses PTSD and substance use disorders simultaneously with a manualized treatment. 12 sessions, 90 minutes for anyone, adolescent, adult of any gender with both PTSD and substance use disorder within the past year. And just kind of in closing, as we're wrapping up here before the Q&A session, all of these integrated models that are going to address trauma and addiction are going to have some component of emotion regulation. That's why I wanted to kind of have a slide all on its own, because if you think way back at the beginning, we talked about how people with addiction are addicted to changing the way that they feel. So really relying on drugs of abuse or compulsive rewarding behaviors that are behavioral addictions as their primary means of emotion regulation, their primary means of feeling good and escaping feeling bad. And so part of treatment is going to be helping our clients learn, develop, employ, and grow in their self-efficacy and confidence in their emotion regulation skills without turning to addictive substances and addictive behaviors, especially clients with trauma that may have trauma symptoms, and because of a dysregulated stress response, because of hyperarousal or hypoarousal, they face even more difficulty regulating emotions. It's really important that we provide this type of training and this service in our treatment to help our clients develop emotion regulation skills. And so there are papers and books written about how to develop emotion regulation skills. I just like to point out that sometimes when people think of emotion regulation, they think of deep breathing. And they're like, okay, so if I'm ever feeling dysregulated, I have to do this thing to help try and make me feel okay in the moment. That's only a part of emotion regulation. It's actually a lot more than that. It starts with organizing one's life in such a way as to increase the probability of positive emotional experiences, and then funnels all the way down to what we attend to and our appraisal of a situation, and then modifying our emotional responses. So if you haven't explored all that emotion regulation has to offer and what a developing emotion regulation skills looks like, I encourage you to dive into that, as it is a vital part of both addictions treatment and work with trauma, and especially integrated models. Okay, so you'll get a handout with more resources, but I just wanted to show you some of the ones that I have relied on for this presentation and for my own learning and training. The Seeking Safety Manual. I really love The Deepest Well, which is a great book by Nadine Burke-Harris. She's an MD, just talking about the impact and the effects of adverse childhood experiences. The Body Keeps the Score by Vanderkolk, we've talked about a lot. Addictions and Trauma Recovery, that's the Atrium Manual. Childhood Disrupted is just another great resource if you're trying to learn about the effects of trauma. Trauma in the Body is by Ogden, is another great resource. And then, of course, Internal Family Systems Therapy, if you're interested in learning more about IFS. And just in closing, before the Q&A, I've done some work with Mental Health Academy that you're welcome to check out if you're interested in learning more about behavioral addictions or working with substance use disorders. This QR code is, it takes you to my Facebook author page that I try to keep updated with relevant information about behavioral addictions and other addictive substance use disorders and chemical addictions as well. So feel free to follow that if you're interested. And then you're welcome to email me as well if you have any questions that we don't get to now.
Great stuff, Amanda. Thank you so much. Always very insightful, very interesting, and you've nailed the timing as well. I think you literally presented for 1 hour and 30 minutes on the dot.
I tried really hard, Pedro. I did that. I was just trying really hard for you to say, well done, Amanda. You stayed at your time limit.
I mean, the content was terrible, but the timing was perfect.
At least we did something right. Yep.
All right. I'm just going to leave this slide for a few more seconds up, but when we provide you with the copy of the slides, all of these will have hyperlinks in them, so, or at least most of them, but you can search online as well. And we will have links to all of Amanda's courses on Mental Health Academy, including the 2 credentials that are listed here. Now, if you're live with us right now at this very moment, please submit your questions via the chat or via the Q&A tab. You can ask anything you want, just no personal questions. Amanda, and obviously you've got Amanda's email there as well. It's going to be in the slides, and it's also on the handout that we're going to provide. So let's quickly switch off now this presentation and make you a big star, and I'll be a little evil angel on your top right telling you to do wrong stuff. But we've got a few questions already here, Amanda, and I thought we would get started with them. Great. And we're kind of going to move around into various topics and some of the stuff that was covered in the session in one or other level of detail. So the first question is regarding addiction therapists being hesitant to address trauma in their work with clients. So how have you seen this come about, and why do you think this can happen at times?
Yeah, I'm a counselor educator, so I work in a training program, and I think a lot of it has to do with what training has historically entailed. And unfortunately, I think there's been in the past this kind of these mutually exclusive groups that I'm either a mental health counselor or I'm addictions counselor. And the mental health counselors work with trauma and mental health concerns. Addictions counselors just work with the addictive behavior. And what we're seeing with this movement towards integrated care is that we don't need that dichotomy. It does not have to be one or the the other. But instead, I personally believe that all mental health professionals need to be trained in addictions, and we need addictions counselors to be trained in mental health so we can provide this integrated care with all co-occurring disorders, not just PTSD and trauma and addiction, but really all mental health concerns and substance use disorders or behavioral addictions. So I think there might be a hesitancy because the training has not been there. That there could be addictions counselors who don't know what assessing for trauma or screening for trauma should look like. And then if a client screens positive or does say, yes, I've had these childhood experiences, how does that fit in then to standard addictions treatment? And what would that look like? And I think that's why some of these manualized approaches that we talked about in the workshop are helpful, not necessarily as like, this is the only way you can do it, but it gives a really nice guide for how to integrate work with trauma and addiction together, especially for individuals who maybe haven't taken a full-blown trauma course and are just trying to learn through continuing education and self-study and are trying to put these things together. I think those manualized treatment approaches can be a great start. And I also think that just as a field, we are learning more and more about the prevalence of trauma among addicted populations. And so we're going to see more resources become available, more trainings become available. So I think the hesitancy is just from that lack of training, a lack of modeling or exposure to some of these resources that hopefully that is starting to change a little bit with what's been produced.
Thank you very much, Amanda. And on the topic of why addiction training is essential for all mental health professionals, we actually have a blog post that Amanda wrote at the MHA blog. So I've actually posted the link here into the chat. If you're watching this on demand, just go to the Mental Health Academy website, click blog, and then just put addiction in the search field, and that will come up as one of the options. And it's a very interesting article, so have a look at that. Next question was just submitted. The question is, as we all know, our service sectors are under-resourced, and I'm sure this is the same case in Australia and the US and many other places. How do we ensure that we have a significant positive impact when interventions are limited?
That's, I think, a very, very real question. That is something that we are facing. I think we're at a mental health shortage just across the globe, that there can always be more resources. I think it's for places where there's not, maybe that are understaffed or there's not as many resources, I always think of, so that how do we maximize the resources that are there, the people that we have there, and ensure that clients are getting the best care. And so right now, research is really pointing to integrated care as the gold standard, that when we can address mental health and addiction simultaneously with the same clinician, that's really seen as associated with positive outcomes. And so for the people who are there, who are staffing that site and that have the availability, I think getting trained on trauma so that the same clinician can engage in addictions work and trauma work simultaneously is really, I think, the goal. I also know that not all organizations can provide those kind of trainings. And so I think getting access to some of these books and manuals for self-study, it's difficult. I really do wish that there were more free resources for addictions counselors about a variety of topics, including trauma, so that the people who are there on the grounds doing the work, they're able to provide this integrated care. And even if it happens just a little bit of knowledge and awareness and skill building over time, just gradually, a little bit over time, that can be really helpful to start to integrate that. And I think one of the best things that we can do is just to start changing our conceptualization. Again, from that, what's wrong with you, to what happened to you, to know that trauma is a predictor of addiction. It's a robust relationship. So even just working that into our conceptualization, that all the clients that we see, we're thinking this could be influenced in some way by trauma. What is a screening tool, a free screening tool in the public domain that I can use, would be a great start to, I think, some of this integrated care and a trauma-informed approach.
Just on the topic of trauma, and I guess the conversation around trauma has considerably grown, especially on
Mm,
social media. And even you look at celebrities talking about it as well. You've
mm,
obviously got people like Oprah who written a book with Dr. Bruce Perry talking about it. It's literally what happened to you,
mm,
the title. But so that's great, and that has really brought awareness to looking at things through that lens. Um, but at the same time, also there might be a concern that the term trauma is becoming commoditized, and it's
mm.
become everybody just calls everything trauma.
Yeah.
You poke your toe and now you're traumatized.
Mm,
What do you think are some of the challenges from both a clinical but also research perspective into making sure that it doesn't become a label that actually brings people down and stops them from progressing and
yeah.
makes it harder for them to take responsibility and take steps forward, take control of
Yeah.
their life? Like, what are your thoughts around that and some of the things that clinicians can do when communicating about this, especially within the context of addiction, because it's
Mhm.
such important personal responsibility, so important in that area for people to really take their reins and make their decisions.
Yeah. Such a great question, Pedro. And as you were talking, I was having the thought that this is kind of the same conversation we have about um, like the neuroscience of addiction or the genetic predisposition of addiction. When we start to talk about addiction as a disease or a disorder with, the neuroscience behind it, then some people I think react by saying, so is that just letting everyone with addiction off the hook because they have this brain disease? And I think the same thing is kind of with trauma. Okay, so now everything is called a trauma and that just explains away or absolves anyone of any responsibility if they have a substance use disorder. That's not, I always go back to the biopsychosocial model that we're not trying to talk about blame and kind of this moralization of addiction symptoms. It's really just a way for us to understand this person's experience that has led them to where they are, which might be our intensive outpatient program for substance use disorders. So I don't think having a genetic predisposition or having experienced trauma absolves anyone of any kind of responsibility for their life, but it certainly helps us understand why a person might be more at risk or more vulnerable for developing addiction than someone else. And I think that helps us as clinicians have empathy. I really like Carl Rogers. He talks about how it's impossible to have accurate empathy if we've developed an evaluative opinion about someone. So if we're kind of judging or thinking that's not really trauma or, oh yeah, genetic predisposition, and we're starting to have that evaluative stance, it's really hard for us to have empathy. And we know that one of the main predictors of positive outcomes in addictions treatment is having empathy and being empathetic. And so I think I like to go to definitions. I like to go to criteria of what trauma is. And I think that SAMHSA definition that talks about this event that was experienced in a life-threatening way that has led to adverse effects in multiple dimensions of life, to me is a really nice definition of trauma. And so there are bad things that can happen, and then there are traumas that can happen. And so I don't think it's all just on the same level. I think we look at how did this affect you? How did you experience this? What are the adverse effects of this? Looking at that continuum, are you meeting criteria for PTSD? Do you have symptoms, but you're like subclinical? Or did you experience a potentially traumatic event and you're really not having symptoms and you're just showing resilience? So I think, yes, with everything, we need to make sure we're not overusing a term or it's not becoming just like a buzzword in like pop psychology, but we're really understanding that traumatic events can have long lasting effects on an individual in terms of their executive functioning, their stress response system, their arousal. So we want to learn more and more about that to try and provide better treatment and better interventions and better prevention. So I think it's necessary I like that it's being talked about more and more. And I think, with everything, like I'm in the behavioral addictions world. So sometimes I present about behavioral addictions and can get feedback of, oh, we're just calling everything an addiction now. And I understand that, but I like that we're investigating behavioral addictions and trying to understand it. And if that means some people overuse that word, okay, but we have criteria for what it means. And so I'm going to keep pointing people back to that criteria. So Those are my thoughts. I don't even know if I answered your question at this point. Those are just all the ramblings that were going on in my mind.
I wasn't really paying attention anyway. I was just thinking about how you probably meet the criteria for the DSM for webinar addiction, MHA webinar addiction.
I love that's my favorite response ever. I wasn't paying attention. It could have been, don't even know.
All right, I mean, no, that's great. That's very interesting. And with regards to interventions as well, there's obviously a lot of new creative solutions coming up within mental health treatment and mental health care. They're trying to utilize some of the modern technologies like VR or apps. They're doing AI sort of support and various other things. With your research on that intersection of trauma and addictions, or maybe you can just speak from the angle of addictions. Are there any new sort of things that are coming up that you're really excited about that you think are going to have a big impact in the field?
Such a great question. And it's funny that, so I just have to put my cards on the table. Like I come from a behavioral addictions perspective. So when I was learning about VR, it was from the lens of, can this become an addiction and in what way? And so looking at gaming on VR and how it can be even more stimulating than non-VR gaming, and pornography the same way. So that's kind of my exposure to some of these things. The only thing I would, maybe a caution that I have is I do think technology and AI and things like that can do really awesome things. We know that for a subset of individuals that have risk factors, it could become problematic for them, this internet addiction, gaming addiction, pornography addiction. But one of the things that I keep coming back to is just this idea that recovery happens in community. And that's one of the bases of AA and the 12-step programs and peer support group programs. And so because addiction is such an isolating disorder and people don't ever really feel fully known and known by others, I wouldn't want either VR or AI or any kind of technology to get in the way of forming these really potentially reparative, corrective attachments with human beings offline and enjoying natural rewards rather than maybe these super normal stimuli that are more rewarding than anything we'd find in nature. So I haven't kept up with how tech could be used in the recovery process or treatment process. I just hope that as we move as a society into more technology, we're keeping in mind the importance of that human connection that, especially for those with addiction, just seems so vital to recovery.
Thanks, Amanda. Do you have any comments or some interesting research on epigenetics and intergenerational trauma and their impact with addiction?
Yeah, so epigenetics, I think, is fascinating in this field. We're looking at how experience can influence gene expression. So that's really what epigenetics is this study of how experiences like trauma doesn't change our genetic makeup, but it can influence how genes are expressed. And so a lot of it is still yet to be fully proven. Some are, kind of hypotheses. But as this field continues to grow, it's extremely fascinating, I think, for addictions work, because what we see is looking especially at generational trauma. It can actually change gene expression from one generation to the next that can change in such a way that it increases a person's vulnerability to addiction. And so epigenetics has been referenced quite a bit in looking at groups that have higher rates of addictive behaviors who also have generational trauma. And so some of the studies that I've read look at native populations that have experienced all sorts of trauma from displacement and broken treaties and all kinds of traumatic experiences, really up until current day racism and microaggressions. And so just continuing to experience trauma and oppression and looking at epigenetics as, does that serve to explain why there are some higher rates of substance use disorders among particular tribal groups, among particular groups of natives, not all. There's 500 and something different tribes and pueblos in the nation, so we don't want to categorize them all together. But I have seen that research of looking at, can epigenetics kind of explain this? Can epigenetics help us understand when a big trauma occurs for a large group of people, and we start to see similar experiences among their generations, and again, linking that to addiction, does it increase the susceptibility to addiction? I don't think we're there yet in the research to say, yes, epigenetics is a cause of this genetic predisposition and increased vulnerability to addiction, but it's certainly been proposed as a hypothesis that we want to explore more. And so, yeah, I just kind of I think it's a fascinating field. I like to read the articles that come out about it. And I think it's taking a very nuanced and sophisticated look at how experiences like trauma can impact gene expression to maybe lead to some of these statistics that we just throw around. Like I tell my class all the time, I get frustrated when I see someone just kind of put up a table of different demographic factors and then just say, and these are substance use rates with these demographic factors, either racial and ethnic categories or gender or sexual orientation. And then here are substance rates and prevalence rates. And I'm like, that gives no context. It gives us no understanding of the bigger picture and the really understanding what is going on with that particular group. It doesn't look at within group differences. So I get a little bit frustrated about that. And I think epigenetics is helping us be much more nuanced in how we understand rates of addiction.
Great answer. Thank you, Amanda. Next question is, how can addiction treatment programs create a safe and supportive environment for clients with a history of trauma to ensure their engagement and retention in the treatment process? That's a big one for a lot of people working in community setups and hospitals, etc.
Yeah. And that's why I really like how SAMHSA outlines the 6 principles of trauma-informed approaches. And I think as a organization or as a setting, you can look at each one of those 6 principles and say, to what extent are we doing this? And I would think that a lot of places do quite a bit, but maybe there's some room for improvement. You may not have ever walked around your facility and gone through all of your intake processes with the mindset of how might someone with a history of trauma be experiencing this. And I think by doing that, we might see little things that we can adjust or change, but then some of the bigger changes might come from acknowledging trauma in addictions treatment, letting clients know that this is something that is okay to talk about here, especially how it relates to your addictive behaviors. I think using some of these integrated approaches, having clinicians that assess for trauma can really help clients feel very validated of like, okay, I don't have to compartmentalize myself and say, here, I'm only going to talk about my substance use. And maybe in this setting, I can talk about trauma, but in this setting, I can talk about family issues. But really just saying, we want to provide you with services to help you meet your goals holistically, like as a holistic approach to you as a person. And so by, I think, even broaching trauma, assessing it with clients, welcoming those conversations, even through a manualized treatment that kind of guides you step by step of what those sessions could look like, could just increase the safety of individuals who've experienced trauma coming to addictions treatment, not knowing what to expect, not knowing what parts of themselves they can bring to these sessions and this discussion, but instead just kind of setting the stage that we have made this setting with you in mind. We have thought through our policies, our procedures. We have thought with this trauma-informed lens, and we feel like this is our best attempt at those 6 principles of trauma-informed approaches, and we are ready to serve you both your trauma needs, but also your substance use disorder needs here in this same setting.
Sounds a lot like the IFS approach, where you have there's multiple, lenses to look at the same person.
Yes.
You've got trauma, you've got addiction, so you're not the addiction patient. you're not the
Right.
trauma patient. You've got
Yeah.
all these labels and all these things, and some days you might be more one, some days you might be other, but the point is you are you, and
Yeah.
we are trying just to find that
Well said,
how to
Pedro.
holistically approach that.
Mm-hmm. You must have been paying attention to that response because that was a really good summary.
Oh no, I just ask ChatGPT now. Yeah. I'm gonna
Oh.
stop being silly now. It's too much silliness for a Thursday morning. Amanda, what are some of the challenges that clinicians might face when implementing trauma-informed care in addiction treatment settings, and how can they be overcome?
Yeah, I think some of the challenges might be what we see from the biopsychosocial model is what do we address first? It might be that the clinician is thinking we need to start with addictive behaviors to kind of instill a sense of safety with our clients, while the client is saying, I'd like to start with the trauma. And so I think anytime we're doing integrated care, one of the challenges is knowing where to start, getting your client on board with that starting place, and then having a plan of how are we going to address multiple things. And I mean, honestly, I think it is challenging to be competent and stay up to date on addictions treatment and trauma informed care. I think that that is a big ask that we are asking of mental health professionals to be competent in both. And so I think that's another challenge, is just like, where is the time? Where's the training? And now that I know kind of where my deficits are, how do I get that knowledge in a way that's accessible and affordable? So I think those are some of the challenges. But I love motivational interviewing. I think that is a wonderful approach, and I just endorse. I love it so much. And I think that when we're trying to get on the same page with clients, like how are we going to address that first challenge of maybe counselor and client starting in different places? I think taking a MI approach of what does the client want to be different? And then how can we help the client voice their own reasons for change? That is a good starting place of where do we see motivation for making a change? And then as we go through the focusing process of MI and bring out menus of options, we can bring in more of either the trauma or addiction, whichever one maybe lacks a little bit of motivation to address. So I think that could be a good approach for addressing that. And then honestly, I mean, I'm very grateful to Mental Health Academy and other programs that see the value in this topic and are trying to create resources for clinicians that are easily accessible. And so I think that's another way. I keep saying that, gosh, we need more training. We need training on this topic. But you can create all the training in the world. If it doesn't get to the people who need it, it's not really going to be useful. And so I think creating resources that are available for clinicians that, yes, I can't go take this, 3-hour doctoral level class, but I can learn through all these resources is a great way for us to equip in the areas that we need to. So those are just some thoughts.
Fantastic stuff, Amanda. Thank you so much. We are getting to the end of this exciting workshop. It's been very enjoyable, and thank you for everyone who is live with us today. I just wanted to give you an opportunity to say some concluding thoughts before we wrap up. It can be anything from recommendations what to do next, or some encouraging words for clinicians out there, or anything you want to say.
Yeah, I was just going to say a couple of things, that there are so many great resources out there about trauma and addiction and how to work with them. And so I hope that, I've listed some, but there's a lot more. So I just encourage you to explore and see what resources appeal to you that you can learn more about this topic. But I think working in the addictions field is unbelievably rewarding for me to be a scholar in this field and an educator in this field. But really the reason why I do what I do is to try to serve the clinicians who are out there, boots on the ground, doing the work, and making a positive influence in people's lives. So I'm just so grateful that you came to today's workshop, that you care about this topic, and for the work that you're doing, because it's invaluable. And I just really appreciate it.
You're saving lives, people. Keep doing what you're doing. I'm serious, Amanda. It's not funny. It's not a joke.
It's hard to know with you, Pedro. Hard to know.
Yeah. That's how I keep mysterious. All right, this has been great. For those of you that are connected with us live now, keep an eye on your email. In approximately 30 to 40 minutes, you'll receive an email with a link to the slides, a link to the video recording, and a link to a handout that we prepared specially for you that's got a lot of recommendations, links to additional resources, etc. If you're watching this on demand, then just take a look at the description of the video and you'll find some links in there. And if you've got any questions about Amanda's programs, just reach out to Mental Health Academy, check out the Mental Health Academy website, or just Google Amanda Giordano, and you'll probably find her Mental Health Academy bio as one of the top search results.
Yeah.
Amanda, once again, it's been great, and I'm really looking forward to connecting with you again soon, which I know will
Yes.
happen very soon.
Yep. Thanks so much, Pedro. Thank you, everyone.